Good afternoon, everyone. This is UMAT TV, United Medical ACO. Welcome to our weekly event. Today, our guest is our state of Delaware's Majority Leader, Senator Brian Townsend. Brian, how are you doing?
I'm well. How are you doing?
Good, good. So I see that we are live, but I didn't actually, I don't know how that really happened because we were supposed to go to the, okay, so it automatically just started, so that's great. So sometimes like the technology does play its little tricks on us. Brian, you were with us several times before, twice before, right? And I know that you guys had a late night last night.
Oh yes, I'm glad you're aware of that.
You know, that was the first tweet that I saw this morning. So what was that about?
Oh, what time you mean? What time were we
last night? Like what was the main topic last night that you guys were working on?
We had a series of gun safety bills on the agenda, 5 or 6 of them, as well as a piece of legislation that will enable Delawareans to vote by mail moving forward. So there's several big pieces of legislation that were not agreed upon by both sides, and it took a long time to sort them out, debate them, call the votes on them. So we finished our session around 12:15 last night. I got home around 2 a.m.
12:13, it says.
12:13. I think technically you're on top of it. You're on top of it.
So now was this a bipartisan moment, or was it just from the Democrats?
Oh no, the votes on those pieces of legislation were only from the Democrats.
Okay, so what I'm maybe hoping to see is like increasing the maybe age and then the background check. And now I have some other healthcare related questions coming up, but I think and I did watch President Biden's answer on this one. Executive order, is that something that he's not able to use for this one? Is it out of his power for the executive order? Because in the Trump time, that was being used very frequently.
Mm-hmm. I'm actually not 100% certain. I apologize. At the federal level, generally speaking, there are certain things that someone can do via executive order, but there are very much limitations to that. So I'm not positive on the various policies. I have to assume that if he could do it by executive order, he would have done it already, or is in the process of doing it. But quite honestly, things have been so active and thorough and intense at the state level the past several weeks on the gun front, given the tragedies in Buffalo and Uvalde, among other places, and just generally with other bills this session that, I apologize, I've not been paying attention to the federal level with regard to that.
So I was actually just trying to understand if there was a way to just do it with the executive order, but he was saying that it was actually kind of like out of his, that it would be, he wouldn't be exercising his power properly if that was the case. So that's what I understood. Now, we have some healthcare related questions, and then if we have time after that, I may have some couple other questions. Now, the American Rescue Plan Act, now the video may not be going at the same time that our dialogue is going, so it's running its own pace. So now the rescue plan, I think part of the issue for us, as you know, we are an accountable care organization, and we are a for-profit organization, which actually on the surface it looks like there's a difference between the profit and for-profit, but that's not the case in healthcare. Right. So we are providing the same service, Medicare, Medicaid, in some cases self-pays, but that's right now beyond our control. But the way that American Rescue Plan Act, the money is being distributed, there's some, it's not proportionate. Like the hospitals are, as usual, they're getting the most. When we do so much for healthcare, it seems like private practices are still kind of like left behind. Is there any way that from the state legislation standpoint, we can make that transition more balanced and then we can be more included?
The answer is yes. And I think beyond not just is there a way, but we should be looking at this and should be working on this. When it comes to the issue of federal funds in the pandemic, although they are spread out over a few years, depending on the nature of the funds, it's obviously overall kind of like a one-time thing. It's important to work on that. And if there's additional flexibilities, I think we should take a look at it. But more broadly speaking, I think that we should definitely take steps to have a bit of a rebalancing of legislators' awareness of the medical field, of the healthcare field, and the various stakeholders and players in it, so that people don't get caught up thinking, oh, it's just what the hospitals say. That very much is pervasive right now. Primary care is an example of it, where people sort of just say to the hospitals, hey, is this good to vote on, not good to vote on? What do you think? And there's an entire other set of stakeholders out there that are so critical to providing care. So it's a sort of a systemic issue, a structural issue, a cultural issue, perhaps, that we've really got to work on. It's not just, I think, it's not sufficient to just say, hey, let's try to make sure we dedicate some of this federal funding to this other provider community. It's got to be more comprehensive than that. It's got to be kind of cultural awareness or a structural awareness of how it all fits together and how we need to have a broader set of stakeholders at the table.
So, yesterday or the day before, I saw this news. One of the hospital systems in Delaware is purchasing another out-of-state hospital. And then, you always understood our issues better than some of the other people in the similar position. So that's why I feel comfortable just telling you this. My first initial reaction was, so as a nonprofit organization, they are being audited, supported federal level and the state level. Now, the state level is important because the nonprofits are benefiting a lot more at the state level in some cases. And now, when that money is invested out of state, I kind of felt like there is some unfairness, like if that money is well spent, especially, this last hospital purchase is not a really busy system, so it's already losing money. And then when I see these out of proportion distribution, it just always like there's this fairness, like, is it fair to do this just because they are labeled in one way versus the other? And perhaps we can, talk about that off the record, some other time. But that's something that we want our state officials to know, that if they are nonprofit and if they are benefiting from the state, those should stay, those investments should stay in the state. And now with the two big purchase, the Crozier,
right.
And the other one is Janesville. And I'm like, why is the money going out of Delaware?
I'm happy to talk about it off the record, but also on the record. I think you bring up a great point about how the community overall feels about the idea of state support or kind of state. It's not the point. To your point, the state structure of laws and policies in the state vis-a-vis a not-for-profit. If it's resulting in resources that then go out of state, I think there are people who are going to be concerned about that. And I'm glad you mentioned Crozier as well, because literally the news in the past, 2-3 days, whenever it was that it broke, it's sort of like, wait a second. Crozier just broke, and that's not even finalized yet. So, what's going on here? It's a very important policy discussion, and I think one, as you put, in terms of people expecting resources in the state, a very fine framing for it. So happy to talk offline about it, and also happy to go back to my colleagues literally next week as we're back in session and just say, hey, everybody, just want to let you know a question that came up to me on a Friday afternoon call is this, and let's all start bearing that in mind. It's really, really important to kind of to figure that out.
Well, I appreciate that. So that's really important for us to at least we all you and I, we discussed these issues before, like different topics, and I hope that's what you also feel. But I try to stay in the reasonable limits. Sometimes we can be, we can be selfish. That's fine. But my approach usually is, it has to be in the reasonable, fair limits. So as long as that happens, it's a fair game. But things are going to happen. I guess we are going to see what's going to happen the next. Now, The other issue we have these days, social determinants of health, is something that we are feeling every day. The SDOH, I'm going to say, social determinant of health. This is changing the way that we are approaching healthcare. Now, you may remember we start doing case conferences. These are daily case conferences with our nurses. Usually there are two teams. I lead one, and then Donna Blanco, our clinical integration director, she leads one. And there are 6-7 people in each team, one social worker in each team, as well as the nurses. So when we go through these cases, these patients, what we understand is the cookie cutter approach, like, oh, well, you have to do this because it's preventable. It doesn't work because they may have social issues. They may have other problems that's preventing those things to happen. And now this is actually changing the way that this is, the healthcare is being delivered. So are you guys, from the state Senate standpoint, are you guys anticipating any issues around the social determinant of health, like how that's going to change the healthcare? Do you anticipate any changes in the future?
I think the answer, it's going to sort of my sensing how my colleagues overall more broadly would answer that question is, yes, anticipating changes, but my guess is legislators feel, when I say guess, I somewhat informed guess, obviously, but is that legislators feel like the changes are kind of already underway, or that it doesn't require more from us, perhaps. That the awareness is out there that social determinants of health is an important way of addressing healthcare, but that it's such a widespread view now that it's kind of already happening. The provider community is doing their thing to help push in that direction. Insurance, carriers doing their thing to try and encourage that. And so it's like I don't want to say it's a fad. No, it's way too serious to kind of use that word for it, but that it's a movement that's already happening. And I even as involved as I've been on primary care, for example, I definitely don't feel like right now that at all in a position to be able to list off additional steps that the legislature should take. But I am all ears for that, because my guess is that although it is kind of a broader movement that's got momentum, that there are things, including from a state payment perspective, whether it's a state employee health plan or insurance laws or otherwise, and Medicaid, that we can do more of. So I would want a list of that. I want to talk to you about that and get a list of what we can do.
I think we should talk, because the other thing right now is happening is around the primary care bill. I was in one of the meetings last week. There's the committee that's actually discussing how the changes are going to happen. It's more on the care coordination payment and how much of the money should be going to the primary care. As I was listening, what I realized is that those individuals who should be actually really representing us, I'm not talking about the state officials in this case, the committee members. Mm-hmm. There's still some out of touch, like what's really happening versus what kind of like the fantasy is. So, and all of a sudden, like, we have some models started, and now we are going to change this model in a way that it's going to actually take almost maybe everything. It's going to wipe out everything that we did. Mm-hmm. Instead of seeing the results of the started projects, now we are actually, perhaps we are kind of like just restarting everything. And immediately, like just to give you kind of a little background on that. So let's say if our care coordination, I'm not going to use real numbers. If our care coordination number is $1, it can go up like 15 to 20 times of it, which sounds good. So you would think that we would just take that and run. That's not the case, because it's changing the value base part of it. So with these changes, especially the state is going to sign off on these final shape of these agreements. I wonder if the services are really properly studied, and then if that's going to be the right thing. Like, I rather just see what we were going to get with what we are doing today, maybe 2 more years. But now these changes is almost like my first initial reaction was, well, what's going to happen to the value base? Because it's good to get the money early, but then it's going to increase our cost of care because it's going to be charged to the insurance. So just to kind of get some background from you, what may be happening, and then how actually we can perhaps impact those decisions.
So generally in this area, we had taken a kind of high level approach. We didn't want to micromanage all the different kinds of innovation that could happen in the provider space. We certainly understood the idea that value-based care is an important movement as well. And although fee-for-service or certain fee-for-service overall or certain aspects of care delivery just don't lend themselves to sort of value-based care measurements. But overall, the idea of value-based care was a movement that is got its momentum. And we didn't want to micromanage sort of exactly how that would have to look. We just wanted to make sure to channel resources towards primary care generally and rely on kind of an iterative process to help us understand what innovations are happening and what's being effective and whether we have to revisit it or not to mandate certain things could be a sort of separate topic. I will say that based on what you're saying here, and I have not been able to make the past few meetings of that group, but if what you're saying here is actually sort of taking steps backward, if it just the nature of this rollout is like disarray, or not in disarray, but just interfering with ongoing efforts, particularly through some kind of prohibition of ongoing efforts right now, then that's concerning. And I'd be interested. I mean, this group doesn't have does not have like immediate force of law to be able to say yes or no to certain things. But between how the Department of Insurance, through its statutory and regulatory powers, will be coming down on certain practices or encouraging certain kinds of practices to move in that direction, or whether or not the Delaware Healthcare Commission will have the ability to kind of move the needle or push certain models, particularly models that are being required by or encouraged by the federal level as well. That's sort of, as I understand it, the mechanism for how this will all change. But that's kind of beside the point. I mean, if your point is ultimately whatever the mechanism is, it is kind of unwinding efforts that right now are bearing fruit or should be allowed to play out, then I would want to make sure that it's not, whether accidentally designed or not designed, but having the effect of stopping progress right now. That doesn't sit well with me. I need to learn more about that to kind of understand how to, what has to change.
In terms of learning, Brian, we are all in the same, position, because even though I'm in healthcare and I've been doing this for so many years, with the value base, there wasn't anything prior to us before we started. So it all started with us. So it was just like kind of try and then see if it works, and it doesn't. One thing though is, and then from the business side, what I know, in order to see the results of the work, that you have to be patient, and you have to be consistent. You have to kind of stay with the plan, because we kind of started with the end goal. End goal was, can we actually change the behavior of the providers and the patients? Mm-hmm. Because this is not just the provider related. So this is, I mean, because going through so many patient records every day, there is a group of patients, certain demographics that we have, and I'm not talking about race or ethnicity or background. I'm talking about how they qualify for like Medicare disability, for example. Those individuals need a different approach, because our regular primary care approach does not work because it's more complicated. Usually they have more issues on the like mental health and others. And I'm just talking from the statistics, because that's how they qualify for. Most of them are qualifying. So that patient is not same on the other side. So if I have just to give you an example, if I have a 67-year-old Medicare patient qualified to Medicare because of the age, that patient is not same as the 50-year-old Medicare patient who comes from the disability. When you have to spend twice more time on the patient visit for this patient than this patient. But our structure is not based on that, and our payment model is not based on that. So I think those are the stuff that's missing. Yesterday, we had a discussion with one of the Medicare Advantage groups, and I give them, like, in the presentation, they had 2 patients who were kind of high cost, and then they are saying that they were our patients, and we haven't seen them in the last 18 months. But patient did choose us as the PCP. Then we tried to reach out to them. They were no-show. And what I was telling them is, look, we are not shying away from the responsibility, but we are really trying to tell you this patient doesn't need our help, because one of them was a cancer patient. Usually, once they have the oncology services started, they're not going to come to the primary care, most likely because they are going through so many visits already. So I think this is just a feeling, maybe, but I see it from one patient to the next, and every time it's consistent that there are a lot of real issues that's not being actually addressed because the model is not that. So I just wanted you to kind of like maybe process that, and then maybe we can have a follow-up. And I don't think it's going to change anything, because I know that decisions are going to be made with some committees. And there were some doctors from like one from one of the ACOs, another one, the person who's the head of the committee is a physician. So it's not like the physician insight is missing. It's the reality of the business is missing. The healthcare, like on the private sector, what happens is actually kind of missing. So, and I was hoping that we can maybe have more dialogue and some follow-up on those to see if it's really needed to just wipe out everything and then restart. So, because if you give us more care coordination money today, that's going to change everything that we did in the last 4 years, because it's going to go against everything that we did before, because automatically it's increasing.
Well, and just to be clear, and I welcome the ongoing conversation, and our legislative session runs until June 30th, and then we're off basically from July 1st to January 1st, essentially. And it's a great time to be able to kind of step back, rest, recharge a little bit, but reflect, and then have conversations that really inform policy and legislative initiatives in the first half of each calendar year. So we're going to enter that time period soon. I would love to have in-person or virtual conversation about all this. I think you put your finger there at the very end, especially on the fact that different providers are at different stages of what their practice looks like and how they're delivering care with regard to adoption of value-based practices or otherwise. And so again, the idea had been high-level support for enhanced investments in primary care without micromanaging exactly what that looks like, because it's going to look different from sort of practice to practice or ACO to ACO even. And so it really wasn't meant to be, and you mentioned Medicare pay, that Medicare is obviously federal. So this was meant to be structured where there are federal requirements, whether they're requirements or whether they're just market shifting frameworks that might not be a requirement because you're not talking about a federally funded patient, but your entire practice changes already. And
well,
so
I was using that as an example, but this was mainly for the Medicaid population, I believe.
Sure. No, understood. But right, again, whether it's Medicare, Medicaid, state employee plan, which is a centralized major entity in the state here. I mean, the private insurance, the non-ERISA private insurance space is so small relative at this point, relative to so many others. So, but it is one we can regulate. We can't touch ERISA plans, but some of them apparently are shifting now to adopt some of the primary care enhancements as they've seen these rollouts. So it's such a turbulent dynamic. I mean, it's turbulent, maybe in negative ways. Dynamic is a more positive sounding term. It's such a moment to try and improve. But again, to your point, or at least as I'm taking your point, some entities, some providers, some ACOs are kind of already down the path. And if we're too micro with how the state is coming in to mandate certain things, you might actually be underserving groups. So that was never the intent. And if it's rolling out that way, I need to learn more about it, and I want to do so on an expedited basis, especially July through December, and then hit the ground in January legislatively to figure out what needs to change.
So no, that's I think the follow-up would be really important for this one, because especially like since you guys are going to be off for a couple of months.
6 months. I mean, 6 months.
Right. So now
I probably should sleep for a couple of months, but yes.
So now there is a question, and remember, like, I don't prepare all the questions. So normally I don't prepare any questions. Usually I go with the open dialogue, but
okay.
There are some other people who are managing me too. So AKA
I was not aware anyone can manage you, but okay, we'll give it a go.
This is a question from Anthony. So like You actually, your college education is in China, right? From like,
I had a master's degree in Chinese studies.
Okay, so but you studied in China.
Yes, it was a 2-year master's program based in England at University of Cambridge, but about half the time of those 2 years was in China and half the time was in England. So when you add that study plus other experiences, I've lived in China for approximately 2 years.
So I think question is, like if you were to compare how we actually approach and how Chinese approach the COVID-19, again, the question is not mine because I would actually answer this question a different way. Mm-hmm. So is there anything we can learn from them? So this is the question from Mr. Anugu.
I definitely have not followed an expert in this, but I will say based on what I do know, I think that what we could learn from some of what they've done is to take things very seriously. You know, there was a split in our population. Some people took things very seriously and some people took the exact opposite approach. I don't know the data enough to know whether or not some of their very serious, and I'll use the word draconian to some extent, measures that they took were actually worth it from a cost-benefit analysis. Even now, you have like cities of millions and millions of people in some instances on lockdown or purported lockdown. So their society and government and economy, well, society and government anyway, maybe not economy, are structured more that they might be able to actually implement those policies in that way. Ours is not. So it's kind of hard to compare. It's very much apples and oranges, but from a broader perspective, I think that clearly it showed a level of government seriousness there, and in other countries, frankly, that the U.S. simply did not show, uniformly speaking. Obviously, some of our health professionals at high level, policymaker level, government levels took it extremely seriously. And God knows that our health professionals took it seriously from a ground level in the trenches. Hospitals and providers took it so seriously, so admirably, so inspirationally, right? But political leaders did not take it very seriously during the Trump administration, I think. In some instances, set horrible examples from a policy or political perspective. And I don't know if that's true in places like China or otherwise. So if anything, overall, broadly speaking, to learn, it would be we should take things like this seriously.
So, you know, because the reason I didn't have the ownership of this question is because I don't think China was being honest with their numbers.
Oh, sure. Oh, yes, from the public health perspective, especially reporting to the world. I don't know how honest they were being internally with their decision making, right? But reporting to the world, I mean, clearly there was a lot of transparency issues there. But on the other hand, then they go into like a lockdown of a major city, which is a very severe policy, perhaps justified. And as always, my answer is more focused on the fact that just shows a level of like, I mean, I'm not trying to wax poetic about it, but that shows a level of like dedication. Like they are all into trying to stop a spread. Whereas in the US, it was kind of like the highest level of a US president saying, oh, a couple of weeks it'll go away. Some sniffles, it'll go away.
You know, like every time we compare, like as you know, like I was born and raised in Turkey, and then last 24 years I've been here. Mm-hmm. And I've been around the world, and then I did go several different places. One maybe sometimes we kind of get used to it, and then we think that it's the same everywhere else in the world. Right. What we have here, in terms of, like, I know there are issues, fine, but overall, when you compare what we have here in this country versus any other, there is no other country can actually match to our level of transparency, level of openness. It's at a different level. So, like, you know, we can have the dialogue without any problems. We can actually voice our opinions. It's so much different when you go to any other country. So it's not well accepted. Even in Europe, it's not. So I think we are lucky.
I agree with some of what you're saying. I think there are some other countries where transparency and openness and sort of discussions in a democratic society do occur. I previously had studied comparative health systems, among other topics that are kind of across, you know, international and so I guess what I'd just say, and actually I want to say it was Tom Friedman in the New York Times wrote an op-ed kind of related to this topic in the past several days, where he kind of actually compared how think it was Tom Friedman, but he basically talked about certain characteristics, including, especially in Europe, of countries that are just actually more advanced than us. A few decades ago, not true, but now their transportation systems, a whole host of different structures, public sector. There are plenty of countries that are just in many ways more advanced or have far better outcomes than the United States. And health is probably a great example of it with regard to spending less amount of money per capita in those countries with better health outcomes. So I do agree that some of the examples, certainly the China example you brought up in terms of COVID, is really hard to compare the US. And certainly in the US, there's a lot more transparency. But look at where the transparency, okay, so we have transparency, but look at the divisiveness and some groups use that transparency, or at least the freedom anyway, the freedom to talk about things that were entirely not based on science at all. And look, history, it'd be interesting how history judges what happened the past few years, because there is no doubt that some of the policies and government mandates probably exceeded that which would be supported by a deeper cost benefit analysis. Certain lockdowns, certain mask wearing, et cetera. You could definitely argue that it was done out of fidelity to risk aversion, right? But I guess my point would just be is I'm solidly kind of in the middle with regard to the idea that there's a lot we can and should learn about some other countries and how they do things. And I get a little bit worried when America is not the best in everything, and in some ways, I'm sure we're the best in some things, but we way overestimate that at this point. So we need to be careful about it. But you're right, there are certain things that we enjoy here, especially from a freedom perspective. But it's a fascinating political and philosophical debate about if you have freedoms and yet they're not used in furtherance of literally a life, liberty, and the pursuit of happiness, right? Living healthier for longer with less mental stress and more happiness. The US is not the place for you. Like there are other countries that those measures are far in excess of the United States. And from a health perspective, our healthcare system is the best in the world if you have good access to it. But there's so much inequity there.
Even with healthcare, I think we are still ahead of those countries. Like I know maybe when we look at the side-by-side comparison, what we spend for one person and access to healthcare is at a different level. Mm-hmm. I have seen some of those. I have friends in different countries where they are trying to get something, and in England, for example, getting an MRI is going to take 6 to 7 months. Right. So you have to get a ticket, and that's going to come to you. If someone needs it today, tomorrow we'll get that MRI done here. So I'm not saying that this is necessary or not, but I think the access and the level that we are probably is a difficult comparison. Now, tomorrow I'm going to Turkey for 2 weeks. Mm-hmm. So after I come back, I'll tell you what's happening there. But it is every time I leave here and then come back, I have this feeling that, okay, so this is the comfort zone. So, even in Turkey, there are difficulties when I always get in trouble. I get warning from my family, okay, no, you shouldn't be too loud about this or too loud about that. And you may think like that, but just, turn down a little bit. I'm going there now and I'm going to hear that again. And here we are a little bit kind of spoiled with the in a way, and then I understand what you are saying though, the freedom of the way that we have, is it being utilized properly? That we can discuss, but so still ahead of the game, I believe. Now, one last question, and I really do appreciate the time that you were able to spend with us. Now, because I have a politician, and if I don't ask this question, it will be just wrong. Uh-oh. The gas prices, what's happening and what's going to happen? Do you have any insight? Are we on the right direction? What's your, personally, how you feel about it?
Well, there's no doubt that high gas prices have a very hurtful impact on a lot of families and also some kinds of businesses more than others. The reality is that gas prices, in the United States are actually low relative to a lot of the rest of the world. The whole world is dealing with, higher gas prices right now. And as much as Americans are hurting, when you look at the actual, comparative figures, There are a lot of other places in the world that have even higher, gas prices than we do right now. It's not the kind of thing that President Biden can do much about. I mean, it's a far more complicated and international issue with regard to supply and demand. And so, as much as it's important for politicians to acknowledge the pain that families go through when the price of the pump is so much higher, it is, I think, not only that's very unfortunate people are going through that, but it's also going to be unfortunate. There are probably going to be political consequences from it that really, even though those politicians have nothing to do with it, but people are going to be frustrated and they might vote accordingly. And the reality more than anything else is this is just yet another reason why we have got to be much more dedicated, much more purposeful about shifting towards cleaner energy and green energy. I mean, we're right now at the mercy of global supply chain issues and global energy supply chain. And, there are ways around that. So it's very unfortunate that we have not embraced them as much over the past several years. It's unfortunate we're probably not embracing them as much as we should right now. And it's unfortunate that there are going to be political consequences, even though politicians have, in most instances, politicians have nothing to do with the drivers of this.
No, that's fair. Brian, well, we really appreciate your time again. Thank you so much for joining us. And I know we'll have some follow-up discussions later on, but having you and you being very humble and then you are available for us all the time, that's really something that we appreciate a lot. So we'll hope to see you again.
Oh, definitely. Let me know and have a safe trip. Don't get in trouble. I guess on behalf of your family, I'll say don't get in trouble. And definitely let's plan to meet up again over the next 6 months while we're on break, and sooner the better, to really start discussing and analyzing, reflecting on things we could do a better job of in the state legislature on the topics we talked about or any other topic. And that way I'm ready to go in January to begin advocating.
Absolutely. Well, thank you so much.
Definitely. Thank you.
So thank you, Senator Townsend. So we didn't do our COVID update. Let's do that. Let's see if I can find my slides.
I thought it was very nice of Senator Townsend's willingness to speak on topics, it may not be necessarily his specialty, but at least, someone from his position and background having the availability, like you say, to be able to join us and hopefully again in the near future.
Absolutely. Like this is, it's all about the dialogue, right? So we are not expecting anything different than the dialogue. So, and we don't expect them to know all the answers, but being able to hear what we have to say, and why we are saying it, those are all extremely important. And we do appreciate him being available. Now, I am trying to get to my video. And now, in terms of our COVID numbers, so let's see. I hope people understand that we put a lot of work behind this this presentation. So sometimes we have these technical issues that we may not be able to find everything right away because we don't have anyone else helping us. It's just Sean and Ethan on the bariatric side.
Yeah.
But here's our COVID video.
All right, we have it. Perfect. Yeah. So with our weekly COVID updates on our numbers, the U.S. is still at the top. However, it did decrease by 10,000 cases a day on average. So that is a good sign. And again, just reminding everyone, the death toll is not proportionate as we've seen in the past. So even though there may be a high amount of cases, the death toll and mortality rate is nowhere near what we saw with our previous variants. So again, that is a good sign. And our second slide does have a visual to kind of show the plateau now that we saw a little rise as we went into the middle of end of spring into the summer. Now we're approaching, but it is kind of flattening out there. So it's good that we're not increasing further above those 100,000 cases that we saw on the weekly average. And of course, with our vaccination numbers, we do have the national and the state of Delaware side-by-side comparisons. We are over 221 million now citizens across the country fully vaccinated. Of those, almost 105 million having received a booster. And then the Delaware comparison actually has increased 0.1% in all of the categories except for the total. It did remain at the 64.7, but all of our categories below hand did increase 0.1%. So it is steadily going up.
All right. So I do want to discuss the economy a little bit more. So now we don't have the senator with us, so we can be a little bit more maybe opinionated. Yeah. So the interest rates are being raised now. So then you know that there are issues. There may be issues related to that. We were expecting that. It didn't happen to now. Now this is the first time that's actually a significant change.
Yeah, so I can attest to that firsthand. So mortgage rates and I believe also student loans are going to be impacted. As we see, the Fed did raise, it was 0.75%, which there's talks that it may end up actually having to go again a little bit further if it's not enough to kind of combat the inflation. This was their attempt to sort of prevent further inflation. We know it was at 8.6% on that average, but of course we do see certain categories such as the oil and other energy resources being at much higher percentages of inflation compared overall. And, you know, as the senator was mentioning earlier, that families are kind of struggling with the gas prices and the inflation of other things such as our meat products, dairy, eggs. We are seeing an increase in that. And just to remind everyone that the reason that we do bring this up is kind of tying it back to healthcare, that if families who may be trying to make ends meet are now being hit with this burden, that there's less money that they can now afford, you know, adequate transportation, certain medications, their co-pays. So for those families who are trying to balance all this extra burden is obviously going to have a potential impact on their health overall. Hopefully not too severe, but it is something. This
increase, like I believe maybe 6 weeks or 8 weeks ago, we did discuss what that means when the Fed raise or lower interest rates. So we are gonna actually see the domino effects. So this is gonna actually make changes in our lives. As you mentioned, this is related to our patients' well-being, because if they don't, some of them are on a limited income, and the financial difficulties from the social determinant of health is one of the 4 main elements, right? So, and maybe we see that more often than the others,
right,
as a barrier to the service. So they are not able to get to, they are not able to afford, they are not able to buy. So the increase is gonna come with those other follow-up increases that we are gonna see. But I think part of it is because we also need to remember how much money is put into the system since April 2020. Some of them was not really necessary, and when you have that much, and that's going to increase the inflation, and this was kind of almost inevitable that we were, because like, you know, I have my slide ready for this one from 2 months ago. Yeah. Is because this was happening. So it's not like, you know, anything new or anything unexpected happening. So that's, right, like, you know, part of the usefulness for me, and I think it's true for Sean as well. Everything that we are discussing is somehow, in some ways, we are actually seeing those. So that means these are predictable. So then we can actually prepare ourselves for the better future. Now, speaking of better future, the gas prices are we're at $5.
Yeah, $5 for our regular unleaded. So.
In case anyone is wondering what I have, so it makes it easier to see. So this is $5. Yeah. So it was $2.53 before pandemic, right?
Yep, and you saw maybe also a $1.94 back a couple of years, but yeah, it's now at $5. And this is, again, just remind us, this is regular, you know, unleaded on the national average, which obviously some states, you know, California, it's like over $7. Mm-hmm. And to remind people that in relation to supply chain issues, and that these 18-wheelers do actually take diesel, so it's not $5 a gallon for them. You know, it's much more expensive.
On the average, it's 6.
Yeah, so it's obviously impactful, and you know, think about some of our previous sessions where you'd show the empty shelves in the grocery stores and how there was an issue with supply chain, and now the gas and being able to transport goods. And as Senator mentioned, in regards to COVID and comparing it to China and the seriousness they took, regards on taking it more seriously and having kind of a universal approach. We have to think similarly to the economic situation where you're saying, printing out so much money in the past couple of years, it kind of was inevitable, like you're saying. And should we just be taken more seriously, and steps could be taken maybe to mitigate or prevent these financial impacts that we're now seeing?
With my experience and with my background with these issues, economy and the healthcare and the inflation, so pandemic did have its own impact in the global economy. So that was already inevitable, and it's probably true for every country. But I think what we did as the leader of those countries, leader of the world, what we did, we spent too much money and we put too much money into the system that we didn't have, because we are so if you are let's talk about two different countries when they're actually trading, exchange trades, so they use dollars, they use US dollar.
Correct.
So it's almost like when someone needs to communicate with someone else in a different country, they speak English. Mm-hmm. So yeah, the default is that.
Right.
So that actually gave us some, I think, made us a little bit irresponsible. So when I say this, I want to be careful. I'm not necessarily saying that we did it knowingly, not knowingly, but because we could do it and it's not going to impact us directly as much as it would impact the rest of the world. I think we just put way too much money into the market. And what happens is now people are spending it. Mm-hmm. Now, on top of that, we put the spending infrastructure bill. That's $4 trillion, right? The total $4 trillion that we don't have. So you are building what you already miss with the COVID-19, and then you are putting more with the infrastructure bill. And this is what was going to happen. So why, instead of trying to look for answers somewhere else, I think we just need to look at what we did, and it's clearly now we are paying for it. But most people also benefited from this.
Yeah, that's not to be forgotten.
Yeah,
there's definitely opportunity that was out there during this, and a lot of people are thinking it could have something to do with the war, but this was kind of in play. The steps are kind of taken way before February of this year, where with the amount of money printed back then, it was going to come up regardless. So the fact of trying to maybe substitute this as a scapegoat, as a world event that, this is having an impact. I'm not saying it's not having an impact, but kind of inevitable, like you were mentioning earlier, it was bound to happen. You're digging a deeper hole. It's bound to catch up to you at some point. And I think this is kind of the beginning of where it's actually seen. We did enter the bear market officially. So
in the next 2 weeks we'll be off. So I'll be in our Turkey office. I do want to kind of see, I talk to them obviously every day, but being there and then see how they're actually dealing with these. So on the way back, after I come back, maybe I can actually give you guys that perspective and what's happening in a different country with the same issues that they are dealing with, but at a really much severe level. Mm-hmm. So now we have our Elon Musk update, right?
Yeah, we had a few slides on Elon Musk.
So he's being sued.
Correct.
For $253 billion.
Yeah. So there is someone who has a lawsuit now against Elon Musk with SpaceX and some of his other companies on claiming that he knew it was kind of a fake currency. This is in regards to Dogecoin, which is one of the cryptocurrencies, and kind of, I guess, claiming that he was, influencing the price rise and gain on his tweets. And I know the person's claim in one of the articles I read was they were saying that no, this is similar to gambling, which I think was kind of ironic because theoretically nobody knows which direction any stock would go unless they're psychic.
So this is my Bitcoin.
Yeah.
So
crypto is down.
So it is right now down to 20,491. So I didn't buy, like so far I didn't lose anything.
It's good.
Yes. But or maybe I'm lying. Maybe I did lose. No, I did buy. I did lose. So I didn't put anything new. So let's say in this last 8 months. So maybe I put $7,500 total. Yeah. So I remember seeing $15,000 for the same amount, and now we are down to $4,800.
Yeah.
So
crypto is kind of.
I'm still not getting out. I don't know why. But this is what we were also maybe kind of predicting. Now, I don't know what's going to happen with it, and I'm okay to lose it if it's going to be totally gone. But there's some hope that it's going to go back because it's going to be opportunity for those people who wants to invest and then just make more money, just like the stock market. Yeah,
it's similar. So in regards to the lawsuit, people.
This is kind of like, this is why I was saying that maybe part of the reason for the lawsuit is because maybe they knew that he had some insight.
Well, I mean, there is insider trading. If you know, say, if you work for a company and you know what their numbers are before, their Q3 results are announced to the public, and you make certain puts or calls on stock options, that's obviously insider trading. But I think trying to blame, I'm assuming this person lost money on their Dogecoin. And just a reminder to everyone, make sure you do your necessary research on the topic before you go all in based on a hunch.
Risk whatever you can lose.
Yeah,
so that's not going to make a big change in your life.
It should be your weekend spending money that you're willing to risk, as opposed to.
So I don't spend that much over the weekend. Well, this was a good session. So Brian Townsend, I think he answered some of our questions, and I know that having working with him before, I know that he's going to follow up with some of those issues that we have. Sean, thank you. And then it was also Sean's birthday yesterday. Now he is a year older than he was last week.
Yeah.
So happy birthday.
Thank you.
And as I said, we're going to be off 2 weeks. We do have our Bariatric Friday coming up in 5 minutes with Dr. Erkan, and we'll be back in 2 weeks. Well, thank you so much for watching us. Bye-bye.